Hi, everyone. I'm Dr. Jamie Arnoff. I am going to be leading today's presentation on suicidal ideation and self-injurious behaviors, providing responsive treatment. We'll start with an introduction and then we'll cover some objectives and then get to the meat and potatoes of today's presentation. So a little bit about me. I am currently presenting from Beacon, New York, in the Hudson Valley. We're about 75 miles north of the city. I grew up here in this area. I went to Boston University for undergrad, majoring in deaf studies and psychology. I went to Gallaudet University for my PhD in clinical psych. So I do have a specialization in not just working with hearing individuals, but also deaf and hard of hearing individuals. I currently specialize at my private practice, BFF therapy, in adolescents and young adults who present with anxiety and depression, many of whom experience suicidal ideation and urges to self-harm. So I have a lot of experience through Kennedy Krieger's family therapy clinic, doing functional family therapy, Children's National Medical Center, doing exposure and response prevention with internalizing disorders, I work at this Real Medical Center, working in their child maltreatment unit, and ASWB services back in my hometown of Poughkeepsie and in their residential treatment facility in Rhinebeck. High out, high volume outpatient clinic, working with children through a wide range of ages and presenting concerns. And so I spent my pre-doc, post-doc, and first year of licensure there at that organization. And so in addition to working at my private practice, I have been completing forensic evaluations through family court in Dutchess County. And I'm also the expert psychologist at the not-for-profit James's Warriors, which pushes into schools to present to staff, parents, and students on youth mental health and suicide prevention. So something I'm really passionate about, and I'm looking forward to talking to you more about this topic, and I'm appreciative that you're here with me. So let's talk about some objectives. By the end of today's 2-hour training, participants will be able to identify how to effectively manage a disclosure of suicidal ideation or urges to self-harm, assess risk immediately and in subsequent sessions, create safety plans, demonstrate effective replacement skills and general coping techniques to use as interventions, and to explain how to modify these techniques when working with minor clients and their families. So since that is one of my areas of specialty, I will be talking throughout today's presentation on how you might modify some of the language or the approach, the disclosure of confidentiality, being transparent, how to navigate caregivers, and informing them after disclosure, things like that, as well as how to work with clients that are 18 and above. So I like to ground us in stats to start. What brings us here today? In 2022, over 49,000 people in the United States died by suicide. For me, the statistics below are especially relevant because it's the second leading cause of death for children 10 to 14 years of age, and the third leading cause of death for those 15 to 19 years old. If you're unfamiliar with the different definitions of suicidal ideation and self-injurious behaviors, think about suicidal ideation and those thoughts as existing on a spectrum. And that will come up in the sense of risk, the nature of the intervention, whether or not there requires a higher level of care. So for me, my automatic response, while maybe overwhelmed, a little bit nervous, typical normal responses that are valid if you experience them once or every time this happens to you, might not be for me to panic, because there needs to be more assessment, more information gathering, and just like hold space for the client who's making this very brave decision to disclose these thoughts, maybe for the first time ever. I think of passive ideation as referring to a desire to complete suicide without a specific plan or intent to act on that plan, while active ideation includes a specific plan and maybe also intent. Self-injurious behaviors is deliberate behavior resulting in the potential or actual injury of oneself, We'll also be talking about NSSI or non-suicidal self-injurious behaviors. Those are considered a significant risk factor for suicide attempts and death by suicide, but they may or may not accompany suicidal ideation. It is without suicidal intent. So I think it's always important to be including questions about suicidal ideation if there's been a disclosure about self-harm, but we'll get to that in a moment. So language does matter. And while I tend to utilize initially the language of my clients, I do think it's important for us to just be aware of evolving language and new terms and vocabularies that have come into the field and might be received a little bit better from those who have perhaps had suicidal ideation, made an attempt before, or perhaps lost someone to suicide in the past. So previously, someone might have said, oh, this person committed suicide. That implies sin or crime and pathologizes those that are affected. And in no other instances of death is blame placed on the person themselves. So to those with suicidal ideation, this can really contribute to the large amount of shame associated with experiencing ideation, as well as this hesitancy or unwillingness to want to talk about it and be able to get help. More appropriate terms that have emerged are died by suicide or completed suicide. So you will hear me say that those terms and use that language throughout today's presentation. When we're thinking about the younger population, if that's a population you're currently working with or some population that you may come into contact with during your work, the CDC runs data, collects data every few years. So in 2021, they found that 22% of high school students seriously considered attempting suicide. 18% of high school students made a suicide plan. 10% of those high school students had attempted suicide one or more times. And 3% of high school students made a suicide attempt that resulted in an injury, poisoning, or overdose that had to be treated by a doctor or nurse. Female students and LGBTQIA plus students were more likely than their peers to experience poor mental health and suicidal thoughts and behaviors. Hispanic and multiracial students were more likely than Asian, Black, and white students to have persistent feelings of sadness and hopelessness, which has been related to risk factors in terms of emotions that can connect to suicidal ideation. Black students were more likely than Asian, Hispanic, and white students to attempt suicide. And while the percentage of Black and white students who attempted suicide increased, the percentage of Asian students who attempted suicide decreased. So the percentage of Hispanic and multiracial students who attempted suicide did not change. Some risk factors that might be important to gauge, even from the first phone consult that you have with a client or a caregiver when they're determining whether or not you're a good fit and you're determining whether or not you would like to take them on as a client, if that is something that you have the ability to do, is go through some of these risk factors. So I'm asking these questions during that initial phone call. This information is something I'm asking about in the paperwork that they get and hopefully complete before I meet them for the first time. And also these questions that I'm going to start really clarifying during the intake session and early subsequent sessions. I want to know about family history of mental health, family history of self-injurious behaviors, of suicidal ideation, of attempts, completed suicides, any history of adverse childhood experiences, or what you might know as ACEs, any prior attempts from the client themselves, substance use issues. Again, this is for the client and the nuclear family, co-occurring disorders, unemployment, again, for the client or for the family. So if caregivers or parents are also experiencing unemployment, that could be deeply impacting the minor client. Same thing with marital difficulties, financial distress, low social support, lack of access to healthcare. It's important to be mindful of that, and access to lethal means. We'll talk a lot about means restriction and deliberation data later in today's presentation when we think about safety planning. and making sure that the home is supportive of the client who's going through this ideation or having these urges. So we'll definitely touch more on that a little bit later. People also ask, fine, I understand the risk factors. I'm asking those questions. What if this is something new and I missed it, or I'm worried I'm going to miss it? What are notable changes that I might see in a student, a client, a family member, a friend, a partner? School attendance and performance shifts. So maybe someone had perfect attendance and now they're having a hard time getting up and making it to school at all. Maybe they make it to school, but they have to leave early, or they go to school and they make it through the whole day, but they're rarely in their classes. They're often in a guidance office or with a school psychologist or with another supportive adult. And the same thing with performance, having an easy time maintaining their attention throughout the day, retaining information, being able to recall that information and perform well under stress for test quizzes and projects, and whether or not that quickly changes. So all of a sudden they find themselves very distracted. They can't really retain information. They're not completing their homework. They're either not showing up for tests, or their performance on tests and quizzes is not what they were, how they were performing earlier. Withdrawal from relationships with peers and teachers. Were they earlier a person who got along with everyone, and now they're really just sort of isolating themselves and not connecting with coaches or teachers or other staff members that were previously supporting? Sleep patterns and or appetite changes. So are they a person who used to be able to fall asleep right away? Their body was tired, their brain was tired, knocked out for a full night's sleep, woke up rested, and now maybe they're having trouble falling asleep. Maybe they fall asleep okay, but they have middle of the night insomnia and they're having trouble staying asleep. Maybe they sleep throughout the night, but they wake up and they're still really tired and not really feeling rested. And with their appetite, were they someone who used to be able to sort of eat throughout the day, feel nourished, feel full, not really be nauseous or queasy? And now they're either never satiated and always need to be eating. Maybe food feels like the only distraction, or are they, experiencing some somatic distress and not really feeling hungry and not wanting to eat, or eating a little bit and not really feeling well? Just things to keep in mind. Are they worrying a lot more? Do you notice mood swings? Any increase in substance use? Going back to these like stomach aches, also headaches for somatic manifestations, loss of interest in previously enjoyed activities. That could be something like playing a sport after school or hanging out with friends after a work day, versus even just being able to sit and watch the newest episode of their favorite television show. It doesn't have to be these big things, they can be small things too. So it's always important to have, these things in the back of your mind so you're asking important questions during session. As I mentioned before, feelings of hopelessness and unworthiness can be really connected to increased suicidal ideation or urges to self-harm. Preoccupation with themes of death, whether that be something that they're reading about, writing about, the media that they're consuming, the art that they're finding interesting, the art they're creating, the writing that they're creating, which also ties to lack of interest in the future. Are they having a hard time getting to school and doing their work because they don't see the point, because they don't see making it to the end of the year, to graduation, to college, or into the workforce? They're not making an effort with social interactions because they don't think it's worth people getting to know them because they're not going to miss them anyway. These are like statements that they might say that indicate that they're thinking about the future, but there's no interest in the future. And also that they might not even be able to visualize the future. And so that's hard for them to like move forward day to day as well, because there's a wall, it feels kind of dark, and a door they can't quite open to see what's on the other side. So those are things I noticed in some of my clients who have an increase in ideation or urges. I do think it's important as clinicians, but also as people who might be working with individuals who know of or are actively supporting a person who's having ideation or urges, to normalize this conversation on this topic that we're discussing today, there is this commonly held stigma that inquiring about suicidality can increase suicidal tendencies. A literature review between 2001 and 2013 examined whether inquiring about suicide induces suicidal ideation in adults and adolescents within both a general and at-risk population. None found a statistically significant increase in suicidal ideation among participants who were asked about suicidal thoughts. The findings of this review suggest that in both groups, the adolescent and the adult population, acknowledging and talking about suicide may in fact reduce rather than increase the ideation. That includes that repeat questioning may benefit long-term mental health. This comes in handy for me a lot as someone who specializes in teenagers and is often nervous about having this conversation with their parents, making a disclosure with me, hoping that maybe we won't have to tell them that session, because they're worried that their parents are going to constantly be asking them questions. How are you doing? Noticing any change in facial expression, anything that they notice that may be cause for concern, which I can reframe as such. They're just asking you these questions because they're worried about you, because they love you, because they want you to be okay. But, the constant prompting both allows for some work with therapists on what language can be used. Are there verbal but also nonverbal ways to communicate what's been going on, ideation wise or urge wise, and how everyone can support everyone else in the home? And we'll get to that in a bit. But to remind them that repeat questioning does, in fact, benefit long term mental health. So you can, give the teen that information and hope that the other ways that you promote more effective communication will allow for there to be less tension about the conversation, because the whole point is to normalize it. This is something that should be talked about at home. So disclosure, always be prepared. And it's important to remember, whether this is your specialty or not, it is hard to hear someone disclose or feel an instant of self-harm. It's normal to feel any one of all of the feelings in response to a disclosure of suicidal ideation, right? The goal is to make sure that while we allow ourselves to feel that way because we're human, the client's not necessarily privy to that internal experience, at least not right away. I do think that there are opportunities, and this is on a case by case basis, and I, leave the decision to you to sort of meet them when they're where they're at of, yeah, this is a really hard thought. And I'll share some of the things that my clients themselves have communicated to me in terms of what they were thinking before they decided to make a disclosure, or as they were readying to make a disclosure to me or to someone else. And to validate those feelings that these things are really hard, that they are frustrating, that they are overwhelming, and that you see that and you feel that, that humanizes you as a person, as a clinician, probably builds a little bit of that rapport, and validates them and their feelings. But at least initially, we're going to hold it together. We're just going to nod and say, okay. And then we're going to continue the conversation in language as though we were reviewing the grocery list. That's the tone with which we are going to proceed, right? Tell me more. I'm going to have questions for you to ask them, and you're just going to keep talking the way that I've been talking this whole time. They're not going to sense any changes in your tone, in the speed, and even if you've mastered that initial verbal response, it's important to pay attention to your body, right? That might be holding tension, and that might be noticeable. This is tough stuff that we're talking about. That's what I call it. That's how my clients and I refer to it. The body might reflexively respond to this topic without your active awareness. So sometimes you might, cross your arms, divert your eye contact away, like lean away, cross your legs. It's giving closed off. And let's take a break from this conversation. That topic was a lot. So it's important for you to be mindful that that might happen, that they're paying attention to everything you're doing and saying in that moment. and to try and loosen your posture and literally open yourself up and lean in to the conversation. You want to be there for them. And that's a way to, explain to them and show them, like, I'm here. We can talk about this. Think about what the client must be going through as they silently decide, are you a safe enough individual to share this information? They may consider it a risk to the relationship as it previously existed. This could be within your first few sessions. And so they're trying to make a good impression, have you like them, just like be a good therapy client. Or this could be a client you've been working with for months or years. And maybe this is the first time they've ever had ideation and made a disclosure. Or maybe this is something that you've been working on continuously throughout treatment, and there's been a period of time where this wasn't something that they were having difficulty with. And now this ideation or these urges have reemerged and they're having to bring it back into the conversation. And so they're going to be considering the relationship and whether or not they want to risk it and what the risks might be. Hopefully, especially if they're minors, they remember once they share with you, it will no longer be their best kept secret, because they're not going to leave that session without other members of their family being invited in to be aware of what's going on and to safety plan for between sessions. And for whatever reason, they may not have been able to share this with them yet. So this might be the first time they're sharing with anybody. Perhaps they've shared with other people and it's not been a great experience. And so, this is a risk. So it's important for us to monitor our verbal and nonverbal response. These are some of the self-reported experiences of my clients behind the scenes when they're deciding whether or not they want to make a disclosure, and like as they are readying themselves to actively make a disclosure, whether that's to me or to a parent, another caregiver, a trusted school staff member, a peer, a partner. They've reported feeling embarrassed that they engaged in self-harm, frustrated that they have suicidal thoughts, sad that they have urges to hurt themselves, scared of how you, as the listener, are going to react, determined to keep this between you two. That often is for my minor clients. And so by reacting in this matter of fact, non-judgmental way, you're communicating, one, this is not the first time you've heard something like this. And I'm pretty open with my clients and their caregivers, their partners, anyone that wants to meet me or, be a part of the treatment, that this is something that I specialize in. And so this is not the first time I've had that experience. I can handle hearing something like a disclosure. My perception of them is unchanged because maybe they're worrying about the relationship, and that I'm a safe place. Talking about tough stuff is why I opened up my private practice. So I'm going to communicate that to them. Now, beyond the disclosure, you have a risk assessment. And I am a firm believer that a risk assessment should be conducted at intake with all new clients. I typically also ask if there's been any suicidal ideation or self-injurious behaviors during like a free 15-minute consult, because I just want to know whether or not this person should be considered high risk, which for me means I would like to make sure that they're available and willing to come in at least once a week. But if that doesn't happen, or maybe they don't have that information, and then the client comes in and makes a disclosure at the first session or even doesn't, I'm still going to ask these questions. I'm going to ask them directly, like, have you thought about ending your life? And then if they say yes, I'm going to ask, okay, do you have a specific plan? That can be, when you think about it, what do you imagine? Is there a specific method you have in mind? Number two, do you have access to the means involved in your plan? Do you have X, whatever that object is? Where is it located? Is it locked? Like, is it easily accessible? And the third question, do you have intent to act on that plan? Have you done anything in preparation? You can even ask them using a scale, right? A Likert scale, on a scale of 0 to 5. how likely are you to act on this plan? Would there be things that would lead you to act on this plan? And are there things that would likely prevent you from acting on this plan? Whether it's thoughts about engaging in NSSI or suicidal ideation, the following initial questions remain appropriate. I do get questions sometimes about what NSSI examples might be. That includes cutting, burning, scratching, or snapping. And then some people ask for clarification on snapping. So that is typically using like a hair elastic or a rubber band and wearing it somewhere where it might not even be noticeable. People are wearing elastics around their wrists all the time, but the purpose of it is to pull and snap on their skin in a way that causes pain. And so it might leave a welt, might leave a mark, it might not. But if they're doing that with the intention of inflicting some sort of harm, then that might be referred to as snapping. So these are the questions that you can continue to ask if it's NSSI or suicidal ideation to gauge more information, right? When did this start? This question is here because we're really just trying to better understand if the thoughts themselves seem connected to something that's happened to them recently. Maybe it's a response to something that happened to them in the past that they were reminded of, something someone said. There's a variety of things, but we're working to build insight here. They may not have been asked these questions in the past, so give them a little bit of time and space to think about it. But we're working to just like gather information that at the end of the session, we can put into a safety plan. Another question, how many times has this occurred? Doesn't matter this is the first time or one of many times they've had this experience. We're just trying to build an insight into whether it occurs in certain settings, certain times of day, around certain people. And then what reduce the intensity, frequency, and duration of the thoughts? How did they cope, right? And also, once you figure out whether or not they have coping skills and what they are, I want to know how effective they were in maintaining management of those thoughts using those skills. Because I have lots of clients, regardless of age, come in and tell me that they have a whole toolkit of skills that they can list off to me using very clinical words. They have long experiences of history with therapists, and or maybe their friends have a long history of therapy and they're talking about their coping skills at the lunch table. But even though they can list all those skills, they may not be able to effectively access those skills in the moment, in a moment as high stress as suicidal ideation moment or an urge to self-harm moment. And even if they can access it, the implementation is not effective in reducing the intensity, frequency, and duration. So I want to go beyond the just what are your coping skills and learn more about the access to those skills and the effectiveness of implementing those skills. Because while they might have a full toolkit, none of those techniques might be working for them in this moment. And that's a great opportunity for you to maybe modify some of them, see them engage in those skills, model those skills for them and with them, and fill their toolkit with more skills. Just because someone is having suicidal thoughts does not automatically mean they're in immediate danger. That taps back into this idea that thoughts of death exist on a spectrum. And I think a lot of clients across the age range are worried that if they make that disclosure, they might be automatically like pulled away from their families, out of their homes, and like sent to a hospital to live for an undisclosed period of time. So give them time to think about these questions, as I mentioned before. No pressure for a quick response because we're building insight, because they may have never made a disclosure before, because this might be the first time they're ever meeting with a therapist. They may not have the answers to some of these questions. So be prepared for I don't know and let them know that that response is a valid one. We as providers certainly don't have all the answers all the time. So it'd be unfair to expect anything different from our clients. And I think by saying that to them, you're kind of normalizing the experience and humanizing yourself simultaneously. Sometimes I'm going to ask them questions they don't know. And sometimes they're going to ask me questions that I don't know. And we're just going to work on it together. Like both of those things are okay. We're both human beings, we're a team, and we can figure this out as a team. So when you ask them some of the questions we've already reviewed and you see them struggling and sort of looking at you and looking away or pulling for something that's not quite there, let them know, like, oh, by the way, if you don't know the answer to any of my questions, you can just say, I don't know. That's appropriate. You want to use their language as a starting point, ask simple step-by-step questions, building insight into these unknown thoughts, these questions that you have. As I mentioned earlier, it's going to be really helpful to clarify these details before creating a safety plan. And if they're a minor, bringing in a caregiver. Because I've been in clinics before where the protocol was at the time of a disclosure to immediately pull up your computer, pull up a safety plan, and then follow the safety plan as you're asking questions. So it makes it a little bit more difficult and less personal when you're just like looking at your screen and typing in word for word what they're saying, not making eye contact with them. It might feel a little scary to them if they're not exactly sure what this form is. Even if they do they trust that it's just a form like for documentation purposes, for insurance purposes? They may have a harder time just like being more open and conversational rather than if you were just like turn away from your computer screen and just like again lean into a conversation and just talk with them about it. It's important to read the room when deciding if pushing a client for that information is a good idea. Of course, as someone who works with teenagers, I can normalize and validate I don't know all day long, but sometimes I might have a feeling that they do in fact know, and there's some sort of barrier to preventing them from sharing. And that's something I'm going to want to explore. And so I might pull a little bit. And I might do that in an easy way for them by referencing something they've mentioned earlier, which answers a question that I've just asked that they are having a hard time coming up with an answer to. So, oh, you mentioned, that this is a time of day that you typically have an increase in symptoms of depression. That's often when your ideation emerges. Like now thinking about it, do you feel like early in the morning before you go to school is more often than not a time you experience that? So you can kind of like reframe things that they've already said. But also sometimes we just don't push. And it's again case by case basis and totally up to you. We don't want client leaving the office more stressed than before they came in. But we're also doing this within a single session. And the disclosure, best case scenario, comes at the start of a session, but might come toward the end. And so we do have to be mindful of the time of our schedules and maybe doing some extensions to make sure you get all the information before that client does leave to ensure that they're safe between sessions. For me, as someone who sees teens and young adults, those after school, after work hours are prime time. So I am booked back to back to back. And so I need to be checking on that time to put a quick pause and say, hey, I don't want to like cut you off later before it's time to wrap up and go. I have a client right after you. Let me just quickly send them an email or give them a call, shoot the text message, letting them know that I need to like postpone the start time by 15 minutes or just reschedule for another day. Because I wouldn't want my next client sort of like sitting in the waiting room wondering what's going on without me being able to communicate that to them, or for that client who's next to sort of like knock on the door in the middle of the safety planning with this client and potentially other caregivers. So it's important to sort of be mindful of all of the things that need to be done after disclosure, how long those things typically take for you. Obviously, again, every client and their family is different, so it might take different amounts of time. but also what your schedule looks like so you can sort of set yourself and the clients up for success. So we're getting to deliberation data and means restriction, which are really important. I think it's so important for us as clinicians to understand. And for some of my clients, I will use this information in sort of my psychoeducation spiel to them. More means restriction than deliberation data, but one sort of leads into the other. So when we're thinking about deliberation of between having a thought or an urge and taking action to engage in self-harm or a suicide attempt, there's been a strongly felt ambivalence reported during that deliberation with competing wishes to die and to live. Research shows that the interval between deciding to act and attempting suicide can be as short as 5 to 10 minutes. In 2001, there was a study in Houston that interviewed 153 survivors. Those individuals were aged 13 to 34 of nearly lethal attempts, and 24% went from decision to attempt in under 5 minutes. In 2009, another study found that 49% of individuals admitted that action was within 10 minutes of their first incident of ideation. So reducing access to lethal means because of how quickly the deliberation occurs is best practice and consistent with several theories of suicidality. Documentation, though, suggests few clients endorsing suicidal ideation are being counseled to remove or restrict access to lethal means. That does not mean that they haven't been counseled to remove or restrict access. That just means that maybe there's a little bit of work to do with that documentation, and we'll talk about appropriate documentation later. But it might be reflective that this is not something that's being discussed, and it is really important and something I incorporate into all of my high-risk conversations. So a number of studies have indicated that when lethal means are made less available or less deadly, suicide rates by that method decline, and frequently suicide rates overall decline. People tend not to substitute a different method when a highly lethal method is unavailable or is difficult to obtain. So when we take that information and what we know about the brief period of time between deliberation and action, we can counsel our clients on things like lock boxes and safe firearm storage. So I always provide psychoeducation on lock boxes and encourage my clients to lock up anything that might be included in the thought, the urge, the plan, especially if there's plan and intent. But things like sharp objects, certain medicines, anything that can be used, in their plan to inflict self-harm. If it's a firearm that you're looking to store, you should get 2 lockboxes, one for the ammunition and one for the firearm itself. The goal with lockboxes is to make it difficult for them to access the means in which they are planning to use to take action. So if you have a lockbox that's code locked or key locked, it's really important that you don't have the key amongst all the other keys in the key drawer in the kitchen. It's not something that would be beneficial to have the garage code be the lockbox code. It should be something that's not written down on a post-it where all the other passwords are written. It should be something that's changed pretty consistently. The goal, again, is if we're talking idea to action in 5 to 10 minutes, and one, they don't even know where the lockbox is, but even if they do, it could easily take them 5 to 10 minutes to try and figure out where the key is, what the code is, how to even open the lockbox and get access to it. And we know that they're likely not going to substitute a different method when their planned method, but also just highly lethal method, is unavailable or difficult to obtain. Those 5 to 10 minutes of means restriction could be the difference between life and death. And so it's really important to be mindful of this. to encourage clients to go places like Home Depot or Lowe's. I know some clinicians who have lock boxes in their office and they just hand them out. Maybe they include the fee in their therapy fee for that day. Maybe it's just part of their overall therapy fee. And for safe firearm storage, because you don't want access and because it's such a lethal weapon, you want it to be as hard as possible. If they figure out the code for the firearm, there's no ammunition there. If they figure out the code for the ammunition, they don't actually have the firearm. If you feel uncomfortable having firearm storage in your home, which you can validate, that makes a lot of sense. That is a lethal method. A lot of local police departments and fire departments will have safe firearm storage programs that they offer. So you can call your local departments and see if they are a department that offers that storage. You can bring the weapon to the department and they will hold it for you there so that you don't have to have the firearm in your home. It will sort of be kept safely. Not anybody can just like check it out and take it home. And once you feel safe enough to have the firearm back in the home, then you can have it returned to you. So that's certainly something to be exploring for your clients, but just for you to recommend that they do if they're worried about it and don't want to, have concerns about how many lockboxes they have for firearms, because the idea of just like having such a lethal method in the home feels too much and overwhelming, which again, completely understand. Have to consider liability, right? If a therapist becomes aware that their client is at risk of attempting, courts have generally held that they have a duty to take reasonable or appropriate steps to attempt to prevent the client's suicide. What reasonable or appropriate steps are, there's not a specific list of actions or interventions which can be uniformly applied in all circumstances with all clients. Attempting to increase the degree of social support available to the client has been listed as one. That might be involving a friend or family member in the client's treatment. Of course, you have to be mindful of consent. It also includes increasing the intensity of treatment, so the number of sessions or the amount of overall contact with the client. Arranging for and consulting with the client's prescriber has been listed as a reasonable or appropriate step, as has been facilitating the client's hospitalization if a higher level of care is appropriate. So not only do you want to make sure that you're asking questions about these things, that you're pushing in supports around these topics, but that you're also documenting that you're doing these things. Every single question, their response, any barriers to treatment, psychoeducation that you provided should all be documented in your note after disclosure is made. So now we're moving a little bit away from suicidal ideation disclosure and into urges to self-harm. A lot of it will have some overlap, but ultimately you're going to just want to start building insight like you would be with SI disclosure. So following up with these few questions, have you thought about what you would use to inflict harm? Where is the object or objects? Do you have easy access to the objects? Is there a specific location on your body you have thought about causing harm? Again, this is just important information to gather before you create a safety plan and inform caregivers, if they're minors, about means restriction. If there's been recent NSSI, so non-suicidal self-injury, I think it's really important to ask where the harm was done and to see the recent injuries yourself. Now, I've gotten a lot of questions and feedback about this. This is simply something I'm asking. I know that some clients are engaging in self-harm in areas they might consider private. The point for them is to do it in areas that no one else is going to see, like their rib cage or high on their thighs. I'm still going to ask. It's uncomfortable to ask, but for me, based on my past experience, I feel it's important to at least attempt to get a visual on the location, the depth of the injury, and the state of the injury at the time of the session. I can ask and they can say no, and I'm of course going to respect that response. I can document that I asked and they said no. And then I still provided the rest of this information regardless of their limit and their boundary, which again, valid and appropriate. But I've had clients who have come into my office wearing like a sweater, and a jacket, saying that earlier that morning they had engaged in some self-harm. And when I asked about it, they said that it was really superficial, that it did break the skin, and that there was some blood, but that they were able to like wrap it up and manage it effectively. I asked to see it, and when they pulled up their sleeves, it had been like sort of wrapped and taped with a towel, and the laceration was deep and open and actively bleeding and required immediate medical attention. So, by asking the question, you're gauging the seriousness of the harm inflicted and alerting you to whether or not they might need to go see a doctor. Because I was able to get eyes on it, I was then able to sort of stop the session right then and there, prep the minor client for bringing in the caregiver so that we could talk about this, and so that they could immediately go to the hospital because they needed stitches. And so again, it might be because a client, especially if you're talking about a minor, an adolescent, because they don't want to make a big deal out of it, because they don't really want to talk much more about it, or because they truly don't understand the implications of the depth or the cleanliness of the wound or the object that was used or aftercare or location. They might just not know. And so they don't think that it's important to give that information. I'm always going to ask. And so I'm going to be managing, all that information. And again, firsthand visual allows not just to determine the seriousness of the harm, whether or not they need medical attention, but to provide them with some psychoeducation about cleaning the wounds at the time of infliction, during the healing process, and after the wound was healed. Obviously, I'm going to connect them with a medical provider that can provide them with that education as well, with the tools and supplies that might be needed to manage that. But again, they might not be thinking about the cleanliness of the object that they're using. Maybe there's been such a good job done at home of locking up objects. They're just like trying to find sharp objects anywhere, and those objects could be really dirty. And while we're not trying to promote any sort of self-harm, if they're going to do it anyway, it's better if they have some psychoeducation about cleanliness of, and healing and things like that. So I like to ask these questions. I document that I do. And again, I completely understand that I might ask these questions and I might be given a no, and that's okay. I'll still give them this information. I'll still give family members the information because we're going to talk about it in that session if they're minors, and I can document that I did. Even without eyes on the injury, it's still, I covered my bases, and you can too. I will assess for accompanying suicidal ideation. I'll ask if they're actively having urges to self-harm in the moment. And if they are, we can try utilizing the skills that we've previously used with the client to see if they do effectively reduce that intensity, duration, and or frequency of the urges. If none of those work, great learning opportunity to teach them a new skill or two that they can practice in session with you, and then encourage them to try those skills outside of session if the urge merges again. These are some self-reported purposes of self-harm that I've heard from my clients, and then replacement techniques that I have used with them. So some clients will say that they felt that they deserved punishment, whether that's as a result of adverse childhood experiences, other traumas, maybe just negative self-talk and distorted and intrusive thoughts. That is why they are inflicting harm, because they feel that they deserve the punishment. Clients have reported discomfort in their own skin due to dysmorphia. So maybe they don't feel like they're in the skin that they're in. Same thing with dysphoria, that they should be in. And they want to, sort of likening back to the first reason, punish their body for existing the way that it is in a way that doesn't align with who they feel they are or how they would like to be. Same thing with clients who experience like medical difficulties or chronic pain. They feel a sense of betrayal from their body. and they don't really connect to their body. They may have some dissociation from their body. And so that is a literal discomfort in their own skin, and they might want to punish the body for making them feel that way as well. Some might report they want to just feel something. They're craving sensation. Maybe that's pressure. Maybe that's temperature. So something cold or something warm. Maybe they're feeling too much and they don't want to feel anything. They're overwhelmed by all the feelings or a particular feeling and they want to feel nothing. Or maybe they're feeling nothing and want to feel something. And whether it is the pressure or the warmth, or to see something or to feel pain, that might trump that feeling of numbness. And so they want that instead as their, that's what's driving their urges. And then last, to see something, to see a scab, to see a scar, to see blood. That's what they're looking for whatever reason. For them, that's what's driving that behavior. So based on that, I have come up with a variety of replacement techniques. The first is to draw on yourself with a red tip pen, lipstick, food coloring, or like these tattoo markers that you see here. So the temporary tattoo markers from Body Mark are great. They come in packs like this. They come in smaller singular packs or pack of 3. I would say the most popular preferred colors for my clients are the first 4. So the black, the brown, the red, and the pink, because those most closely resemble scabs, scars, blood, any sort of mark, a welt that they burn, that they might encounter by inflicting some self-harm. If you want, I mean, it's a marker, so you can draw any shape, any size. You can combine colors. You can also use these to like make pretty designs on an area where you might have the urge to inflict harm. And so like it draws your attention to that area, but in a different way, and allows you to sort of like reframe your urges for that area. Like maybe instead of cutting in that area, I'm gonna like draw myself this like beautiful flower mural. If you work really hard to wash it off, it will come off in a day or two. But if you just like wash as normal, these will last for up to a week or two, which is pretty impressive. For the food coloring, that taps into some reported preferences for blood, like for seeing the blood, not for any other reason, but to like have blood and to see it. And so it was like the act of like blotting an injury with a tissue and looking at the blood. And that's sort of what like relieved the pressure, satisfied the urge. And so I carry different color food colorings, orange, pinks, and reds. And I have tissues all over my office. And so we'll like sort of drop different food coloring colors on tissue and have them see like what blots the best, what color feels closest to them. And then I'll send them home with their preferred color food coloring. And so one of my clients who like endorsed this as an urge needing to satisfy would have like a separate area in their closet that they would go when they were previously engaging in self-harm, and they would go to that area and they would use like pull some tissues and just like put the food coloring droplets on it. And of course, it's not ever going to completely satisfy the urge, but if we can do that within that like 5 to 10 minute window and prevent them from ultimately obtaining something sharp or harmful that's really going to cause them physical harm, then I think it's a worthy replacement. Temporary tattoos satisfy need for touch, texture, temperature. You can use really cold or really warm water. Again, they can put it somewhere, anywhere on the body, different visual feedback. So in an area that they want to pay attention to that they're not, or in an area that they were previously drawn to for self-injury, but now they're wanting to make it something different, something more beautiful, something more positive. And henna also can be a really great replacement. Henna, which does come in many colors, but most of which do strongly resemble a scar, a scab, blood. They can be drawn in whatever, place, size, shape that you want. they dry and they crack. And so it sort of looks like a scab and you can pick it like a scab, which some people like to do. And then once you're done picking it, it leaves a mark, it leaves a scar, and that scar will often last for at least a week or two, so longer typically than temporary tattoo markers. The only thing that I caution clinicians about when thinking about henna, if you're going to send your clients to get it, but also if you're going to keep some at your office and like sort of dispense it as necessary, is to get the paper cone henna, because a lot of the henna, I want to say most of the henna like that you'll see um, early on for sale, like as the top sellers, are typically plastic bottles with like a thin, sharp metal applicator. And while if just like drawing it on using that probably wouldn't break the skin, like it's a sharp metal object. If used in a particular way, it certainly could become harmful, and that's sort of defeating the purpose of the replacement. So I would say, I wouldn't go for that applicator, and I would go for more of like the paper cone ones. But yeah, these are all tried and true BFF therapy, replacement techniques. I have had clinicians ask if it feels like it's leaning too much into like parallel play or engaging in the exact same type of behavior and not working to pull them away from these urges. And I understand that ideally we want to move these clients away from these thoughts and urges and actions, but that's not going to be something that happens overnight. So if I can push in supports that they can take with them, they have access to at like local stores that I can purchase and provide to them from my office, and that's going to keep this client going when she's overwhelmed to this closet where she normally would engage in self-harm, but she's blotting tissues with food coloring, and that's enough to like get her to another skill that we're using. Eventually I will pull her away from that action altogether, but she needs to like lean into other distractions while still working to satisfy that urge, because if she doesn't, she's likely or more likely to potentially react the way that she would prior and maybe engage in self-harm. So that's something, that's just been my experience. And I know everybody's a little bit different in how they want to approach this, but these are things that I found to be very accessible within my practice. So when I think of brief interventions, again, when a person's in crisis, cognition becomes less flexible, and these clients don't have access to their usual ways of coping. This is not the ideal time to come up with solutions to reduce their pain and problem solve. So this shouldn't be our expectation for them. The goal of prepping clients with brief intervention is to provide options other than self-injurious behaviors, which was sort of my earlier point. You want the alternate actions or activities to be determined by the client and documented in advance, which can also contribute to their sense of agency and internal locus of control, because up until this point, they may not feel at all empowered or at all in control. And perhaps the engaging in self-harm was the only time that they felt like they were taking control of the situation. And so by giving them, sort of a hand in what these brief interventions are, what they look like, how they're modified, when they should be utilized, that's sort of contributing to their sense of agency and their internal levels. I like to encourage clients to use their surroundings to ground themselves when they're overwhelmed, because that's where they are in that moment. Whatever they're around, that's what they have access to in that moment. Cognitive skills can come later. And that's not to say I'm not going to prep them and equip them with cognitive skills. I certainly am. But I wouldn't expect a client who's so anxious or so depressed that they're having intrusive thoughts of wanting to hurt themselves, and that's all that they're thinking about, and they're worrying about their safety and what do they do, and is there a plan, all these things that we've been talking about roaming their mind in a big cloudy mess. Finding the toolbox accessing the skills and implementing them effectively is a big ask. That's not something I want to like expect from my clients. And I wouldn't want them to feel badly if they couldn't see the toolbox, if they couldn't access the skills in that moment, if they couldn't implement them effectively. So what can you reach for? And if you don't have anything to reach for, how do we equip you with things to reach for? And so first I break down the five senses and try and figure out what their natural, tendencies are within the five senses. So I might ask them, openly, what do you do when you don't feel good and you want to feel better? And see if they fall within these five senses. But after they give me that open answer, I'm sort of going to prompt them through each of them. So, are you a person who likes to watch movies? Take and look at pictures. Are you a person who likes mood lighting? Lots of my teens have all different color lights that dim. Some of them prefer to be in the dark. I see some of my clients in the dark. It can be really impactful light. And so, like, is that something that you like to do when you're feeling overwhelmed and need to be distracted or need to decompress? Maybe you're a sound person. Do you have certain playlists that you like to listen to when you're feeling down and you want to feel better? Or when you're feeling down and you want to kind of lean into that feeling to move through it? Can you not fall asleep without sound machines? Are you a guided meditation person? Do you do that every morning, every night before bed? Are you a person that has panic PJs or pain PJs? Like, come home from school, come home from work, and you put on the clothes that feel so good on you, fit you the way that you like, have, pockets and hoods and places for everything. That you just are looking forward to all day. Like, what are those soft materials? Do you have things that squish? Do you things you can pull apart? Are you a temperature person? Are you a person that finds that like long hot showers solve all of your problems? Or even quick jumping in or doing like a cold plunge? Does that like shock your senses? Same thing with smell and taste. Are you a person that has candles, stickers? Is cooking and smelling and tasting nostalgic or familiar food really helpful for you as a coping technique? You a flower person? I always have food in my office, both for clients that maybe are too anxious to eat during the day. And so they come to me right after school or right after work. And so they'll have like granola bars. But when we're making coping kits, which we'll get to next, I have chocolate, things that are spicy, like fireballs, like spicy cinnamon flavor, things that are sour, like warheads, and again, familiar foods. So having things, I like to have things that are minty too, because again, some clients have somatic manifestations of their emotional experiences. So they might be feeling kind of nauseous or queasy, and mint can always be good, but just like hot and cold showers that some people report just like snap them out of it, spicy or sour foods can do the same. So these are some pictures of coping kit supplies I have acquired over the years. And while I do specialize in adolescents and young adults, I do have clients through their 40s that I do these coping kits with, and they love them just as much. And they come into my office after months of having done this and ask if they can see my little coping kit tubs because they need a refill or they need to grab something. So most of the stuff I got at the local dollar store. I choose to purchase them myself and build these kits with my clients. And then I send them home like with this bowl or this basket of stuff. You can choose to have one or a few of these things. You can choose to direct your clients to the dollar store aisle and maybe give them like an image or have an example of a bowl or a basket in your office that they can be using while they're with you. But again, I feel like it's really helpful for them to have something to reach for. And so I'm happy to provide them with some of this stuff that, again, is from the dollar store. And because of that, it's accessible to them after the fact. Because I'm only going to make this with them once. They're going to have to figure out what works for them and refill it after. But you'll see things like fuzzy socks, vanilla and sweet apple scented candles, things that shake and make music, like slime that squishes, glow sticks, fireballs, mints, warheads, Hershey kisses. I have notebooks and like mechanical pencils for journaling. I have like brightly colored paper that they can write positive reframes or thought challenges on and put all over their rooms. Um, you'll see on the left vertical picture on the top, there's those three little hot pink like finger protectors. I think those are meant for people who are like knitting and crocheting, or like using a sewing kit to protect their fingers. But for my clients, some of them might dig their nails into their hands and break the skin, or scratch themselves, or like dig their nails into somewhere else in their skin and cause harm. So, again, replacing the um, action with something a little bit safer as we work them away from it. If they're going to do this with their hands anyway, this is a reflex to most of them at that point. At least their fingers are protected. So their nails aren't going to dig in. They're still getting this action of doing this, and they can build insight into, oh, I feel myself doing this, but I'm not actually inflicting harm because my fingertips are protected. So when is it that I'm now noticing that this is happening? What was happening before this occurred? Is there something happening right after this occurred that I'm worrying about that's leading to this urge and action? And with that insight, how do I move myself away from this so I don't need my fingers protected anymore? I also put in my coping kits these cool down cubes. They can also be used for clients who are struggling with frustration tolerance, um, or just like anxiety in general. But I find that they're just helpful really with any thought or urge, especially for people who are so temperature sensitive. And ice cubes are great, right? A lot of clinicians might say run your hands under cold water. And I'm a big fan of that in terms of mindfulness, or like hold an ice cube in your hand. That's great. But the likelihood that you can carry ice cubes and like keep them cubed, but then once you hold them in your hand, they're going to melt. That might burn. And then it's wet and it's a mess. Not all clients like the sensory experience. These reusable ice cubes are big winners. First of all, they're beautiful. So it taps into this like color idea. They're filled with water. So they make a like a fun water filled sound, tapping into already two of the three senses. Now you've got touch because they're cold. You can keep them in the freezer. You can keep them in the fridge. You can even write short prompts like in black magic marker on different sides of the cube that when you are holding it, you are looking at it and it's like in your face, a reminder of a skill that we might have talked about that they can use in that moment to distract themselves or redirect themselves. But it's such a great thing to do for them to hold. They're tiny enough that they literally, as most of the things in the coping kits, like can be held in the palm of your hand, in your pocket, in your purse. And so the goal is to make a bowl or a basket and determine before they leave what are places in their life that they're likely to experience stress and overwhelm and likely to experience urges or ideation. That's where these baskets and bowls should sit. And they can be separated into little bags. Like you could take a couple of items and put them on the nightstand if falling asleep or waking up is really hard. You can put them on the table where you do your work. You can put them in your purse, your glove compartment, your backpack, your locker. Like these can go everywhere with you. And once you like have them try the different items, there will likely be a priority sense that emerges, probably one or two at least. And then you can tailor your recommended coping skills to the senses that they most easily reach for, have access to, and use effectively. So this is information for everybody. And again, it's just something for them to literally reach for so they don't just go inside when they're so overwhelmed cognitively, and equip them with that for sure. And we'll talk about that. But this is definitely my first line of intervention. So can't recommend it enough. For clients who are not as into my suggestions to journal, I have blackout poetry as a recommendation. So, blackout poetry is basically taking any existing text, so magazines, newspapers, books, and taking it page by page or paragraph by paragraph and taking typically a black magic marker. It can be any color marker you would like. And you're basically blacking out the words that you don't want and leaving a message that you do. It could be a full message like this, it could be a single word. You could go through the experience and might not be any words left. There might just be a period or an exclamation point. But the idea is for some clients who don't want to be writing things down or don't necessarily want to be writing their own personal feelings down because that feels too close to home, then reflecting on it from the perspective of someone else with a piece of work that had nothing to do with what they are currently experiencing is easier for them to connect with. So this person had left. I had been treading water, exploring the depths, following all the way down. It was a cold and lonely place. Then it occurred to me, such power. The sun sends a dazzling band of light across the sea, a shining sword in the water. It's beautiful. And it can be anything that they want. It can be something that leans into some uncomfortable feelings that they're having, some hard urges that they're having, and it can redirect them to some really positive, hopeful urges and thoughts that they're having. And if they're interested in building more peer support or just connecting to community in general, there's a whole community of Blackout poets. You can go to like poetry jams. There's forums that they can go to, online things where they can communicate and share their poetry or see other people's poetry. So there's just a lot of good depth to this skill. I'm a big fan. I always have. Books that I've already read that I don't care about, or magazines or things, getting Psychology Today magazines. And so that they can take them home and utilize the articles as needed if I'm done with them. So highly recommend this as an option for clients in addition to or as an alternative to journaling. Most of my clients, regardless of age, are walking around with some sort of technology on them. Most of my teens have phones, same thing with my young adults. And so apps are important as an intervention that I might recommend. So these are all tried and true BFF therapy approved applications. Calm Harm uses comfort, distraction, expression release, and breathing activities when an urge to self-harm presents itself. It's password protected and it doesn't say like, hey, are you having a thought of wanting to hurt yourself? It's sort of like, do you want to ride the wave? And it allows you to choose which of the categories of activities you want. And then they have like short and longer options. And there's a long list of activities that you can choose from. And if you haven't fully ridden the wave, then you can click another one. And it gives you a mood and effectiveness tracker, again, for more insight building, as well as a list of contacts if still needing support. For my clients who engage in self-harm, this is our favorite app to use. Insight Timer is an app that has thousands of guided meditation exercises. WhatsApp uses CBT and ACT techniques to help manage a variety of presenting concerns, as well as short and long-term coping skills. Think Ladder offers a choice of themes, shared distorted beliefs, and insights to challenge negative beliefs and redirect your automatic thoughts when overwhelmed. So they provide you with a variety of different categories that many people find to be stressful and use a CBT approach to challenge distorted beliefs. And it comes together in this sort of beautiful, colorful story that you can send as a notification to yourself or as a reminder or have an alarm or make as your background of your phone so that, again, you're seeing it in your face and it's reminding you every day of the ways that you can reframe some of that negative thinking. And Flowly combines virtual reality and biofeedback training to regulate breathing and reduce anxiety. So you can use your phone, but they do have like virtual reality glasses that you slip your phone into that makes it a fully immersive visual and soundscape. There's a biofeedback portion because they're tracking your heart rate variability using a sensor, and you are following along with this world that they've created. And there's so many different versions of those worlds that are using your heart rate variability and your ability to inhale and exhale appropriately and sort of utilize inhale, stop, hold, exhale to regulate your breathing and your heart rate variability. And when you get into a flow state and you're regulating and stabilized, then you are interacting with the world in a different way. So you are truly immersed in this virtual visual soundscape, and things are happening because you are participating in it. And a lot of people find that to be very immersive and helpful and distracting because it's like all that they see and hear. Very customizable. Highly recommend. So we've asked all these questions, we've built insight, we've given them some skills. Now it's time for the safety plan. What is that including? Identification of the thoughts, feelings, and experiences just prior to a crisis that a client can learn as a signal. Listing the effective actions they found helpful at earlier times of distress in their life, or maybe that you've just gone over with them in session. The plan should be feasible and accessible with the goal of providing options when the client may feel like there are none. Make it personal and list things the client are actually going to do when in distress. Again, we're working on empowering them. We're working on giving them a sense of agency and internal locus of control. So empowering the client will allow them to trust their own knowledge, be an expert on their own experiences and what helps them best. And they'll be able to lean on themselves because I'm only with these clients once a week for an hour, best case scenario. So I need for them to feel confident in utilizing this plan and implementing these skills with support from other people, but sometimes on their own in between sessions. I like to include warning signs that a crisis may be developing. That might be warning signs because there's insight into times of day, certain people or places that might lead to more intrusive thoughts, ideation, or urges. That might be things that they themselves feel or see, like a desire to want to go into their room, be alone, be in the dark, not talk to anyone, not really hungry anymore, feeling really anxious and nervous and nauseous. But it might also be things that others might be noticing in them that they're not even really realizing they're doing or saying. And so, for a minor in particular, that might be something worth reviewing with the caregiver prior to the end of that session. Specific activities and or places that will distract a client's attention away from suicidal thoughts or urges. People who can help an individual distract themselves, and people with whom they can discuss their distress and suicidal thoughts with and feel heard and supported. So, with these people, with this emergency contact list, I have them put down their name, their phone number, and their address because a lot of my clients, again, regardless of age, have all this information stored in their phone. But what if their phone dies? For some reason, their phone breaks. They lose it or leave it somewhere, or it's just they can't access that information, then they don't necessarily know what that phone number is, what that address is. So I put it on their safety plan, and some of my clients will take parts of their safety plan and put it in their wallet or put it between their phone case and their phone so that they can see it, or it's hidden there because it's a case that's not see-through. But those are things that I recommend for clients to have on them. So if for whatever reason they don't have access to that information stored in their technology, they're carrying it with them in that way as well. Now, if we've gone through this, we've done the assessment, we've done some intervention, we've done the safety plan. If they're a minor, it's reminder time. So these clients may have nodded and confirmed an understanding when you went over the limits of confidentiality during the intake. but later forget the conversation ever happened or feign misunderstanding that it happened when you remind them of the rules. Once they admit to having suicidal ideation or engaging in self-harm, I have to notify people that are outside or coming to get you, the people that you're going home to make sure everyone's aware so that we can all work together to keep you safe. Reactions to the reminder have included, oh, they're going to freak out. They're going to send me away. They're going to hover over me. And it's going to be so annoying. That's where that repeat questioning data comes in from earlier. I won't be able to do anything without them asking me a million questions. And you can say something like, okay, well, we still have a little time left. So again, we're being mindful of time. Let's decide how we're going to share this information with X, whoever outside, so we're all on the same page before you leave. It's so important for me to allow the client to decide how this is communicated. So I'm giving them options with how to proceed with inviting their caregiver in to share this information prior to the end of session. I might start using the language caregiver because I might not know for sure if it's a biological or adoptive parent, if it's a legal guardian and not someone biologically related to them. I want to know how they're referring to one another, and I'll use their language moving forward. But caregiver feels like a safe way to address everything before that. So the options include me as a therapist. I can bring the caregiver in. I can stay in the room, and I can be the one to share the information gathered during that session. The client can be present or not. Obviously, beforehand, I'm going to have a little chat with the client about what we're going to talk about, how we're going to talk about it, and we're going to have some kind of like code. Like I'm going to wiggle my glasses, I'm going to play with my earring. I might, make a cough, take a drink of my coffee, hold it for a second, make a comment about like, oh, this is really warm or this isn't warm anymore. Lots of things that you can reach for in your space as a code word, but no one else is going to know. And they might indicate to me during that code word of, oh, I'm ready to jump in and start sharing information. I thought I wanted to share information. I don't want to share information anymore. Can you please take over, Jamie? Secondly, I as a therapist can bring the caregiver in, stay in the room, and just be quiet. I can just support the client who wants to share the information themselves. Same idea. I can jump in if they give me a little earring pull. And third option, client can get the caregiver and share the information with the therapist waiting outside of the room. I'm lucky enough to have an area where there's a shared work area, my office right here, and then around the corner is the waiting room. So I can give them privacy. I'm also close enough to hear if something escalates. I'm going to be mindful, and I would encourage you to do so as well in terms of option number 3. It's case by case basis. If I don't necessarily know how the caregiver is going to respond, and obviously we can't know for sure, but I'm going to take all of the information I know about them and recommend that they don't do that without me there if this caregiver is more likely to panic or escalate into anger or reactivity at new news or news that might be overwhelming. I'm going to be present, but I'm allowing the client to control how their ideation and urges are communicated to their caregivers in session and in between session. So if the client does take me out, I'm going to be right outside and they know I'm coming back in to make sure that everything was covered, everything was shared, all the information was gathered prior to the end of session. Once you go into the room with the caregivers, be ready to validate big feelings, right? Big reactions, totally valid. Be honest about your experience with the population in an effort to express your readiness to continue working with the client, or the possibility that based on your lack of experience and your comfort level with this presenting concern, a referral may be appropriate. And I wouldn't want anyone to feel like they failed the client in any way, or that they didn't do a good job as a clinician. If that's what they had to do, I think you're doing an amazing job supporting the client by recognizing that it's not something you're comfortable with or feel competent and confident in. And so being open and transparent about that is the best way that you can support the client and helping them, refer and find another provider is the best way to connect them to appropriate supports. Empowering the caregivers to see themselves as a support to clients between sessions is a role of ours with the caregivers, and also having a list of nearby resources in terms of helplines and higher levels of care to hand out. So I am in Dutchess County. We have a Dutchess County helpline. We have a stabilization center, which is open 24/7, 365 for mental health and substance use concerns. And then not super local, but within 45 to 60 minutes, there's multiple inpatient units for minors, and quite locally, many hospitals with inpatient units for adults. So I sort of have all of the names, the addresses, the admitting phone numbers, and we'll work with them on, how they can call those numbers, how I can support them in putting in a referral for that information. But I kind of just like have a piece of paper accessible that I can print out, hand to them, email to them, however they prefer it. So I want to make sure that all information gathered using the outlined questions that we've covered today have been conveyed to the caregiver prior to leaving the session. I'll review the safety plan with them and add any helpful insight and coping skills that they might have had that the client has not thought of or mentioned earlier. So again, the idea that they might notice that the client withdraws or is quiet or skips dinner or doesn't want to go to school the next day, things that they just might not think about. The caregiver can add that to the safety plan. I'm also going to discuss coping skills that were practiced with the client in session and found to be effective so that the caregivers can prompt the client if overwhelmed between appointments, and then advocate for, then insist if necessary, for the increase in session frequency so that the client can be monitored on a weekly basis. It's important to validate for clients and their caregivers that it's difficult to talk about this tough stuff. And so if the client feels comfortable using their words between sessions, they don't have to provide every detail. And that's, again, the working with the family on how to communicate with one another, how to ask how the other is doing, how to communicate how they're feeling, and what best ways that they can support one another between sessions. If verbal response is not the way, lots of nonverbal opportunities. Here's an example. I have had clients who've used different colored scrunchies on the outside doorknob of their room to inform family that they have ideation or urges and haven't managed. Like, listen, this is a thought that I'm having. It's just another thought that I'm having. I have no plan or intent. I'm not going to do anything about it. I'm feeling okay. I'm just trying to be open and communicative and transparent because this is out in the open now. Second color, I'm having ideation or urges and would welcome a person present, please knock, to help them through it or just silently support me. Like, come in, don't try and fix it. You don't have to say anything. I just want you to sit here and be with me. And then third color, I have ideation or urges and I need immediate support or I'm going to take action. And obviously leaving a green color scrunchie on the door until someone notices that and then pushes in for support, maybe not the best idea. So there's going to be other ways to communicate the crisis and need for immediate support that we can work out together as a unit that feels comfortable for everybody. But this is just one way. I have clients who put their water bottle outside their door if they need help, or use certain emojis that they're texting back and forth to their family members. And there's a grid or a key of, okay, this emoji means this emoji means that, this emoji means that. Lots of ways to be creative with it. So important to document. I have a risk section in my progress note that I fill out every single session with each of my clients. That includes options for ideation, intent, plan, and attempt. I'm going to, there's also not applicable for me. So if none of them apply, but I'm assessing it every session and documenting. So completed a risk assessment for ideation, denied recent or active ideation, suicidal ideation, or urges to self-harm, or endorsed recent passive ideation without intent or plan. So I'm going to go through each one. If I check any one of those boxes, it's going to open up to a free text option, and I'm going to document as much as I can. keep a record of the safety plan on file, just for your records, but in case the client loses it or wants you to send it to them. And note that the caregivers were updated, reviewed the safety plan, and received a copy, as well as were provided psychoeducation on means restriction if it's a minor and you're bringing them in. Some of the most commonly utilized therapeutic interventions for working with this population include family therapy, in particular if they're minor clients. That work is going to be around validating emotional experiences, building language and skills for emotional expression, helping family members feel more comfortable with difficult feelings, talking about the tough stuff, as well as CBT and DBT. So CBT, you're helping clients change the way they respond to their automatic thoughts, and you're helping them understand, but also de-link that negative thought behavior movement pattern. For DBT, you're working with them through the modules, right? Mindfulness to be in the moment, emotion regulation to decrease feelings of being overwhelmed, interpersonal effectiveness to promote social skills, and distress tolerance to make it through crises and acknowledge reality. I use DBT diary cards with a lot of my clients. It's for individuals at high risk for suicide. You know, it's important to remember suicidal thoughts and urges, they may fluctuate weekly, daily, even hourly. In addition, high-risk clients may experience weeks or months without any suicidal thoughts or urges to self-harm, only to have those thoughts or urges reemerge at a later point. I often have clients complete a diary card that includes daily ratings of these thoughts and urges. For insight building, it allows for routine monitoring at the start of every session, which is critical to enable us as therapists to intervene when suicide urges are high, as well as to assess factors that lead to increases and decreases in urges over time, as well as what might be working as a coping skill. But I use them because it's allowing for a week by week tracking to see, okay, I had this amount of urges. Maybe the urges start to decrease and it doesn't feel like that, but you're able to look at it and see that. Maybe you're able to stay stable for a long time and then you have one urge that's too overwhelming and you take some sort of action and you feel like you have taken 12 steps back. But you can look at all of the times that you were stable and you had one misstep and then you were stable again for a long time, or you found your way back to stability. And so it reminds them that progress isn't linear, that they've done hard things before, and that we'll continue working on the tough stuff. So this is what a diary card looks like. This is a very, very basic version of a diary card. If you go online and look up diary cards, you can see ones with dozens of columns. These are meant to be accessible and easily completed. So I broke this one down into the date, non-suicidal self-injury, so both urgent action columns. We're exploring, for the purposes of this activity, emotions around it, and then I added a little skill section so that they could put whether or not they use the skill and they could check off. So I start the date of the diary card from the date of the session that we're in, and then I give them a week worth of days to fill in, and they can put X's or stars or check marks. They can use colors if they don't want it to be readable. But ultimately, I'm asking them either at the start of the next day or the end of that day to complete this diary card. Did they have urges or actions that day? What were the emotions around that? It could also be, well, like, what were the events happening? What time of day was it? Were there certain people, places, or things? And then using the skills, and then you can mark whether or not it's helpful. But again, it's allowing them to keep track of things. I might ask questions, and if they're not tracking it, doing a risk assessment at the start of session, they may not remember the answers, but I can say, okay, let's pull out your diary card. Maybe they have it, and we can use that as a jumping point for conversation. Maybe they don't have it, and then we will complete it together and utilize that as a way to remember what went on. But I think it's a good habit to build. For future sessions, it's really important to remember the safety planning is an event that takes place at one particular time. Assessment of a client is a process, especially when we're thinking about liability. And so, for protection against liability, an ongoing assessment of suicide risk is necessary. We as providers cannot effectively intervene to reduce suicide risk unless we know that suicide risk is present. I'll inform clients on the date of a disclosure that every subsequent session, I'm going to conduct a risk assessment. If they're stabilized, it doesn't have to take up the entirety of every session. They know I'm going to ask, that I'm going to be direct, and I'm going to ask the specific follow-up questions. And if it's no, that's fine. If it's yes, I'll do some more follow-up. If they're endorsing that recent or active ideation or urges, I'll pull up their safety plan. I'll assess the effectiveness of their coping skills. It might be an opportunity to modify what the safety plan looks like, resend them an updated one, make sure they have the local resources easily accessible to them if they need it, and they just like know what those resources are, and maybe add to their toolbox of techniques. For clients 18 plus, ultimately, I want all of my clients leaving our offices feeling safe and remaining safe. I discuss with every single one of my clients the benefits of obtaining assigned consent to reach out to whoever they deem appropriate in times of need to that supportive individual in their lives. And this for me has come in handy in times of crisis, but also if they miss an appointment. These clients are having sometimes persistent passive ideation or active ideation, even if there's no like active plan or intent. It's something that, I'm monitoring very closely. Maybe they're about to transition to a higher level of care. Maybe they're coming back to me after being in a higher level of care. And so I'm always going to discuss the benefits of, yes, you are an adult. If you make the disclosure, technically, I have to maintain your confidentiality, and I'm not going to tell anyone. I'm not going to call anyone. But if there's a crisis and you're going home alone and you're not necessarily going to make the call, do you feel comfortable with me wanting to support you to reach out to someone and say, hey, this is what's going on. Can they come spend some time with you? Can you just go check on them? I just wanted you to know that this is happening, just so there's additional support in their lives. Again, best case scenario, I'm seeing them once, maybe twice a week, for an hour. Also, these high-risk clients, they come every week, but sometimes, especially during the summer, I will say, they forget that it's a Thursday or their phone died and they can't get in touch with me to let me know that something has come up. They're not feeling good. They got kept late at work, some car trouble. And so they don't have access to technology. They're missing their appointment. And I'm sitting there waiting for them. And then you know how it goes. I'm going to sit. I'm going to give them the allotted time. Then I'm going to email them and I'm going to say, hey, it's me. We had an appointment. Just checking in to make sure all is well. If you need to reschedule, let me know. If after, halfway through the session, I still haven't heard from them, I'm going to give them a call. And for the high risk clients who've given me consent on the call message, I'm going to say, hey, this was your appointment time. This is always your appointment time. It's unlike you not to be here. I sent you an email, just making sure all is good. Please get in contact with me when you can to let me know, if you need to reschedule, when you want to reschedule, the deal. If I don't hear from you by the end of the appointment time, I'm going to reach out to so-and-so for whom you've provided consent and just check in to see if they know where you are, if they're with you, things like that. So that has come in handy with me, for me when I've had clients, high-risk clients who have missed an appointment, all for, reasons that I mentioned. They forgot it was their therapy day. They got held up at work. Their phone died. Their car broke down. They just couldn't come and they couldn't notify me. But also in terms of crisis, I rarely have to use these consents, but I also rarely have resistance from adults when I explain the purpose and the intention of my ask. And they often do provide some consent for a partner or a close peer or a family member, just to have on file so that I can support them if I don't have immediate access to them. So that's something I might, encourage you to do as well. Okay. It's so important to ask all of these questions for the clients, to prepare yourself for these conversations, to validate yourselves in feeling all the things that we feel at the time of disclosure, at the time of intervention, just within this work. We are holding this space. We're keeping all of these feelings, but we need to release that ourselves to be, you know, managing our own self-care and being the best providers that we can be for these clients. So when working with suicidal patients or clients who are engaging in self-harm, clinicians often report experiencing intense negative emotions. That includes fear, guilt, anxiety, self-doubt, hopelessness, and frustration. The weight of the quick decisions that we have to make around this topic in a single session within an hour, sometimes less, can be really heavy. So it is normal to second guess yourself at times because no scenario is exactly the same. I've been doing this for over a decade. It's what I have sought out training in. It's what I have like opened my practice to work with specifically. I'm inviting it into the room. I'm formulating this specialty around it. I'm passionate about training other people in the assessment and treatment of suicidal ideation and self-harm. And I still feel overwhelmed and sometimes caught off guard at the time of a disclosure. And even though I go through all of the questions and all of the steps and document in a way that I would say beautiful, I'm still worried sometimes. And I need to check in with people that I did everything that I was supposed to do. Was this question okay? Did I forget any questions? Does this documentation seem right? Did I forget anything? Did I miss anything? What do I need to do next time? What did I leave out? All these questions that come up for me. And it's really beneficial in an effort to take care of ourselves, to participate in peer consult groups, to utilize supervision, to engage in therapy yourself. Because again, we're holding the space, we're keeping the feelings. We need to release that ourselves as well. It's like the oxygen mask on an airplane, right? We have to put the mask on ourselves before we can look to the left and right and assist those that are nearby. These are some references that I have utilized in the composition of today's presentation. I'll give you a second to take a look. Lots of work with the American Foundation for Suicide Prevention. They have local walks that support individuals who are working specifically with those who have difficulty with suicidal ideation, but also support families who have experienced loss, and providing, mental health support for those that are actively struggling. So definitely, if you are interested in volunteering or participating in Dutchess County, they have a walk every year, the walkway over the Hudson between Poughkeepsie and Highland, but they are doing multiple walks for a variety of different areas within suicide prevention all around the country. So I highly recommend getting involved with that group if you are interested. But yeah, feel free to look more into the updated CDC research as it comes out, because they're constantly making updates. While they might not overhaul the whole data set every year, they are making adjustments to different portions of the research that they're collecting on an annual basis. And here's some more, research, some good articles utilizing DBT and CBT, more information on deliberation data and means restriction, if that's something that you're interested in. Again, I'm more of the belief that it's important for us to have that information, not necessarily to communicate it to our clients, but I do find that sometimes psychoeducation around the deliberation data and means restriction can be really helpful. There's some resources if you're more interested in the dynamics of pain and people's experience with self-harm that we didn't necessarily delve into today, but some individuals who provide services for self-injurious behaviors and their clients might find to be really helpful. And if you do have clients with chronic pain, which is something I do work with quite often, the last resource, Rachel Zoffness, Dr. Zoffness, she has created a chronic pain and illness workbook for teens, and she has a separate workbook for adults, and I would highly recommend both of those workbooks. Very practical in terms of information, psychoeducation, and step-by-step like ways to participate in intervention, and then there's space for you to complete with the client or for them to take home and complete on their own. These sort of like CBT based approaches to providing therapeutic intervention for chronic pain. And because a lot of clients who experience chronic pain might have suicidal ideation or experience self-injurious behaviors, it's a great resource. So I highly recommend if that's a population that you serve as well. I really want to take the opportunity to say thank you so much. Thank you for your interest in this topic and for your willingness to engage in this work, even if it's learning about it and again deciding it's not for you. Eventually, you're going to get a client who makes a disclosure, whether that's a disclosure about something that's happened a long time ago and they're not currently concerned about it. It was something that happened not that long ago, but isn't an active concern, or something that's actively occurring that you're going to have to manage in that moment. It's really helpful to just be aware of the different research on the topic and on the therapeutic assessments and interventions found to be most effective with this population. For anyone interested in consulting with me more regarding current clients or on the topic, I'm happy to do so. Feel free to reach out to me via our website contact page. So again, at BFF Therapy, at bfftherapy.com. Again, I'm in Beacon, New York. If you are nearby, certainly reach out. I'd love to collaborate with other clinicians. And I so appreciate you taking the time to join me today. So thank you very much.
I hope you enjoyed this continuing education course from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or the link in the description to purchase the course and take the post-test. If you're looking for more CEs, check out our unlimited plan. You will get unlimited access to 150 plus ASWB and NBCC approved continuing education courses for one low annual fee. We're always adding new courses. Did I mention we also have 5 free CE credits available too? Check it out at agentsofchangetraining.com.